my name is Diana.
Brenda.
Marielle.
Jean Marie.
Charles.
Our project is based on the proper use of peripheral intravenous catheter use, and this topic for the project was suggested to us by the 6th floor director at the Centennial Hills Hospital, basically due to inconsistent implementation of peripheral IV protocol, and also a policy that is based on outdated evidence. In order to see the compliance with the policy, we conducted a small survey in which we looked at orange caps on peripheral IVs. We looked at the date and time on the IV side and labeling of the IV tubing. At the time of the survey, 6 out of the 36 rooms were empty, and our results, as you can see on the slide, orange cap compliance was at 66.70%. So 20 out of the 30 peripheral IVs had orange caps. The time and dating on the IV side has a compliance of 56.60%, and 83.30% of the peripheral IV tubings were labeled.
So we assessed the current protocol and compared it to the most evidence-based practice, which allowed us to identify the gaps in the peripheral intravenous catheters on the 6th floor. We gathered the data on the unit through a compliance survey. Evidence showed nursing staff lacks compliance with orange cap use, marking IV date and time, and labeling IV tubing. So the goal is to make staff aware of current evidence-based practice to improve patient outcomes and decrease PIVC complications.
Looking at the research, data shows that more bloodstream infections are related to peripheral IVs due to increased number of usage and mostly inconsistent disinfecting technique. The first literature review we conducted was based on the use of orange caps and its importance. Orange cap eliminates the variation in technique when cleaning the hub compared to the scrub the hub technique, and most importantly, it stays on the hub, which prevents microorganisms to enter the intraluminal surface. A study was done at the Methodist Hospital over a period of 21 months, and it shows that bloodstream infections dropped by 43% in peripheral IVs after using orange caps alone.
So another part of our research was the considerations for peripheral intravenous catheter insertion. And peripheral intravenous catheters are the most commonly used methods to administer fluids, medications, and blood products. PIVCs are less invasive than central lines and are meant for short-term access, and they have a lower risk for infection. Two important factors to consider when providing best practice for PIVCs is the indications or need for placement, the techniques and infection control procedures used during the insertion. So some of the indications, as we already know, they are for short-term use, 6 days or less. The recommended duration of therapy is to exceed 6 days, then we want to insert a central line. The selection for cannula size is also important. The catheter size will affect the volume and speed of the medication to be infused. And the medication and fluids to be infused should be compatible and with an osmolarity of 600 or less. The insertion procedures. Perform hand hygiene and use gloves, as we already know, for infection control to protect self and patients. Clean the insertion site with 2% chlorhexidine and 70% alcohol solution at least 30 seconds. This will decrease risk for infection while puncturing the skin. And secure and cover PIVCs once inserted to avoid infection. The dressing must be clear to allow visibility to the site, and this will also allow us to assess for any complications after insertion.
So another study that we did look up was rotation of peripheral IV sites, because in the policy it says to rotate them every 96 hours. However, rotating peripheral IV sites is actually not cost effective because it uses up materials that otherwise are completely perfectly functioning. It can also be time consuming because it takes time to actually start a new IV, and it can take multiple nurses depending on whether the patient is a hard stick or anything. And also, we found in the study that there is a book out there called Clinical Nursing Skills Basic to Advanced Skills, and it suggests to rotate the IV sites every 96 hours. However, the CDC makes no recommendations of this aside from nursing clinical judgment to change the IV site due to complications. In the QI study that listed this book, they actually assessed the IV sites at 72 hours, 96 hours, and even past 96 hours. And they used phlebitis and infiltration as an assessment and used their own scale tool. And they found that about a third of the IV sites actually remain free of complications for 96 to 200 hours, which 200 hours is equivalent to about 8 days. As Brenda said though, that usually whenever you start a peripheral IV, you only expect to use it for 6 days, but there can be times where it actually extends past that. Also, about 5 of the 89 IVs showed patency almost all the way to 12 days, and then 4 actually were patent after 300 hours, and the longest one that they saw without complications was actually 350 hours, which is approximately 15 days.
Okay, so it's estimated that over half of all hospital patients have intravenous catheters. Inserting a peripheral intravenous catheter is one of the most common invasive procedures that takes place in the clinical setting, yet more can be done on the nurse's end when it comes to observing, assessing, and documentation. So one of the main complications that arises from improper use of PIVCs is phlebitis, and there are 4 types, which is chemical, mechanical, infective, and post-infusion, which occurs up to 48 hours after the catheter is removed. Some other complications that occur are infiltration, hematoma, and rarely, but it happens, in air embolism. So the most important thing to reduce the risks of complications when inserting a peripheral intravenous catheter is the placement. So it's recommended that we place the catheters on the forearm of the vein instead of near the joint, so the hand, wrist, or antecubital fossa. This reduces the risk for occlusion, accidental dislodgement, and phlebitis. So early identification and intervention is crucial too to prevent serious adverse events like tissue or nerve injury that could persist to compartment syndrome. If burning or stinging along venous pathways occurs, you want to stop the infusion, disconnect IV tubing, remove the catheter, and elevate the affected limb for up to 48 hours. So documentation is super important to reduce the risk of PIVC complications. We are held accountable for what we do, so that way we can go back and see what was going on. It also shows a high standard of professional practice, even though sometimes documentation is often overlooked, especially when workload is increased. So what's useful? In New Zealand, they use a pre-printed care plan. So this includes patient information and consent, date and time of insertion, name and signature of cannulator, location, type, and gauge of cannula, indication for use. And then the ongoing documentation includes cannula checks, making sure the dressing is intact with date, time, and initials, flushing the cannula to make sure it's patent, and also when you remove, you want to put the date, time, and reason. So by improving and being more aware of these things, not only will it increase patient outcomes, but it will also reduce healthcare costs by decreasing hospital stay due to unnecessary complications.
All right, so I'll finish it up with comparing the current policy to our literature reviews. So with the literature in each category here, we'll start with always try to select a site away from joints. The current policy doesn't really make any mention of this. It doesn't place an emphasis on where we should look for the site. I know most of our nurses try to get it away from the joints, but we see a lot of IVs in the ACs. So we want to keep the IV sites away from this because it can compromise the op site, cause phlebitis, and also stop the infusion. Flush once per shift and pre-post meta administration. So the current policy doesn't make any mention of the once per shift, I would say. Our evidence shows every 24 hours at least, but once per shift is probably the best practice, so that whenever the nurse comes in and assesses their patients, if they don't have a current infusion, they can just flush to make sure the IV is patent, and then that way it won't fail during the day or like right before a med pass. Do not change the catheter sites after 96 hours. This is what the literature says. So the policy, current policy says change it. Remember, there's no evidence that says that there's an increased risk of infection or that the IV is going to fail after 96 hours. And so there's no real need for the policy to require us to change the IV every 96 hours. It's wasteful, and it can, I mean, you're going to restart an IV, a pain IV on a patient that is already there and already upset. We don't want to upset them any further or waste or cause any waste. Change intermittently, use tubing every 24 hours. So the current policy says 96 hours for the IV tubing in general. And that's okay for the constant infusion or the continuous infusion, like the 0.9% sodium chloride or the lactate ringer. But for the piggybacks is really what we're talking about here. So we'll usually start a piggyback, and then once it's finished, leave the tubing there, and it'll be dated for like 96 hours, and then we'll use that tubing 24 hours later for another medication. That's actually a practice that should not be continued. Those tubings used intermittently need to be changed every 24 hours. All right, so in conclusion, orange caps is the way to go. Scrub the hub is a practice that there's variation in the practice depending on how the person is scrubbing the hub. Orange caps will eliminate that. IV dressing labels, we do document these things, but you also want to add on the labels so that we know for sure, anybody assessing the patient can know how long ago that IV was placed. Select sites away from joints. This can minimize complications. IV tubing labels. Okay, so secondary tubing should be changed every 24 hours. So not 96 hours for the secondary tubing. And then proper cleaning before IV insertion, 30 seconds. Okay, thank you for listening.